Okay, our next topic is something that's relatively uncommon, but something that's very important, and that's crush injuries. This is something that we see periodically. Hopefully we don't see very many of these, but it's certainly something that you can make a difference in relatively quickly to keep them from deteriorating to the point that they can have cardiovascular collapse. So crush injuries, you see those in a couple different mechanisms. One, we see them in natural disasters, building collapses from earthquakes and tornadoes. We see them in bombings. Hopefully we don't see that, ever again. But as well as I do, that we will see activities in which we have building collapses from terrorist activities. You see them in trench collapses, in industrial accidents. And basically what crush injuries do is it's an acute peripheral ischemia. Basically that just sums it up. You get an acute peripheral ischemia, and you get a cascade of events that can be detrimental to the body. We again see these probably more times than not in industrial accidents, probably those trench collapses, a wall collapses at a construction site, etc. And usually when you see this, it's more from a peripheral injury, from a peripheral extremity injury. And you need to keep things, how do you diagnose these? Mechanism of injury, obviously, but many times we won't really think about it because a wall fell on someone's leg and they were under this wall for 20, 30, 40 minutes, and we really don't think crush injury. But even with an extremity, especially lower extremity, that is crushed, you can get this same cascade of events that can release potassium into the bloodstream. It can cause a cascade of events that we're going to talk about that can certainly be detrimental to the body. But one of the biggest things is the 5 P's of peripheral extremity ischemia, and that's pallor. The extremity is just pale. You have numbness or paresthesias. You have a pulseless extremity. Pain many times is out of proportion to clinical findings, and obviously paralysis, just that extremity is injured and neurovascularly is devastated and you can't move that leg or arm. And let's talk a little bit about the pathophysiology of crush injuries, because I think it's important to understand that before we talk about the treatment. So again, one, you got to identify, and that goes along with a high index of suspicion of what a crush injury is, what leads to a crush injury. And basically summing it up from a pathophysiology, and this is a very simplistic way of explaining it because it's a huge cascade of events. But if you get a muscle that is compressed, and again, crush injuries depend on 2 things really as far as the severity of it. The muscle mass. So if you get a finger that's crushed, it's probably not going to cause a lot of pathophysiology, long-term or major pathophysiology to the body. But if you get both of your lower extremities that are crushed with large muscle mass, and certainly it can cause some major problems. So one is the amount of muscle mass that is compressed, and number 2, the time of peripheral ischemia. Those are the 2 big things that you have to keep in mind with crush injuries. But once you reach that point where you have a crush injury, then the cell membrane, especially the cell membrane of sort of large striated muscle, can leak. And when that cell membrane leaks, if you remember, and this is cleaning out the cobwebs from your schooling that you've had in the past, but when your cell membrane leaks, your potassium leaks out. Potassium doesn't cause problems intracellularly. It causes problems when it leaks out and gets into your bloodstream. So that cell membrane is leaking. Potassium floats out. Sodium floats into the cell. So they just exchange places because the ATPA pump is damaged. When that happens, the cells can swell because the sodium goes into the cell. Water follows sodium, as we all remember, and you can actually get a relatively hypovolemic state in the body if you have large masses of muscle that are compressed. Also, the cell releases myoglobin, and the myoglobin can be bad on the kidneys. It can damage the kidneys, and we'll talk about how to treat that. And the potassium obviously can have detrimental effects on the heart. It makes the cardiac membrane unstable and can cause dysrhythmias. And also lactic acidosis can be a result of all of the muscle compression. There are two sort of mechanisms and two scenarios of death that's caused by crush injuries. One, immediate death is usually caused by cardiac dysrhythmias and cardiovascular collapse from potassium, and then delayed death, days, weeks, months later, is because of kidney failure, because of all the myoglobin that's been released and it is damaging the kidneys. So how do you treat crush injuries? One, again, high index of suspicion, and you've got to keep that in mind, and also those 5 P's that we talked about with peripheral ischemia. So what do you do? Well, obviously ABCs, as we always talk about. Pain control. Many times these people will be in severe pain. Pain's out of proportion to clinical findings. Stabilize ortho injuries. Many times, as I've already mentioned, these people have tremendous orthopedic injuries. Fluid resuscitation. These people can certainly have a relatively hypovolemic state. And the number one thing, I guess, is probably bicarb. And bicarb we don't use a lot in the pre-hospital arena. However, this is a case that you have to keep in mind that bicarb can be life-saving for these patients. And basically what we talk about with bicarb is that bicarb ought to be used earlier in the treatment of these patients with crush injuries. If you got a patient that's pinned underneath the wall, pinned underneath the building collapse, in a trench collapse, etc., you really ought to start giving the bicarb before you get them out, if that's feasible. And sometimes, going back a little bit, one of the things I guess that you probably need to keep in mind is on a day in and day out basis, we can certainly see crush injuries from pelvic crush injuries. Patients are caught between 2 vehicles or a vehicle and a wall, etc. So what does bicarb do? Bicarb drives potassium from the extracellular into the intracellular compartment. Again, as I mentioned, potassium on the inside of the cell really doesn't cause a lot of problems. So it drives that in, it stabilizes the cardiac membrane, it alkalinizes the urine, so basically it makes the urine more alkaline, which will help with the myoglobin. We try to keep that myoglobin from sort of settling in the kidneys, for lack of a better term. That's what we call precipitation, but it just sort of settles in the kidney and then affects the renal tubules. So if we can alkalinize the urine with the bicarb, then certainly we can keep these people from going into renal failure. And also it treats lactic acidosis. So can't stress enough the use of bicarb and the pathophysiology of how we get to that situation of needing bicarb and then what bicarb does. So again, bicarb drives the potassium inside the cell, it stabilizes the cardiac membrane, treats lactic acidosis, keeps the myoglobin from settling in the kidneys. And we're talking about high dose bicarb. You're talking about 1 milliequivalent per kilogram IV. That sometimes can be a lot of bicarb, and you can do that as an IV push, or you can actually mix a couple amps of bicarb in a liter of half normal saline if you got it. Many times we don't have that in the field. We just have normal saline, and that's fine too. And run that at a couple hundred cc's an hour. One thing that I will touch base on, as far as another, I guess, scenario in which we see this sometimes is with construction personnel with what we call suspension trauma. They're in a harness, they're above ground, working on scaffolding or whatever, and they fall, and it takes 30-40 minutes to get to them, and their pelvis is constricted by this harness. So those people would benefit from getting bicarb before you ever got them out of the harness, if that's feasible. So crush injuries are something that hopefully we don't see a lot of. Again, they're relatively uncommon, but there are some scenarios that we will see that from time to time. And again, I can't stress enough, early identification, high index of suspicion, and then bicarb.